afternoon, everyone. So I'm here to present our study entitled Dunstan Baby Language Efficacy in Decreasing the Parenting Stress Levels of Housewives with 0 to 2-month-old infants versus standard care using a quasi-experimental study design. So, a new baby brings so much joy to the family, but parents cannot deny that caring for their babies involves frustration as well. Persistent crying in infancy, which occurs at 2 to 3 weeks of age and peaks at 1 to 2 months, causes emotional distress to mothers and may lead to loss of self-confidence in their parenting skills. If the demands of the infant are not appropriately addressed, it may cause emotional distress to mothers, which can lead to a low level of self-confidence in their parenting skills and exhaustion. We felt a need to address this problem by finding a method that will ease this kind of stress. So it also increases the chances of the mother to have exhaustion, depression, and heightened anger, which can affect maternal-infant bonding. So the Dunstan baby language is an 8-year research done in Australia and in the USA. It is an innovative discovery by Priscilla Dunstan in 1998, wherein she discovered that babies aged 0 to 3 months create specific sounds distinct of each need that arises. She classified them into 5 sounds. So here are the sounds. So na means hunger, e means the baby wants to burp, air means lower wind or colic, he means discomfort, like if the baby is hot, cold, or wet, and o means sleepiness. So I'll be showing you a video after this presentation, so you can listen to the babies speak their sounds. So DBL, as evidenced by studies that used it as an intervention, significantly decreased parenting stress, increased maternal self-esteem, and made mothers more relaxed and in control. Indeed, correctly interpreting a baby's language leads to appropriate responses and better communication, promoting decreased maternal stress and increased maternal self-esteem. This led us to come up with a study with a general objective to determine if DBL is indeed efficacious in decreasing parenting stress levels with primiparous housewives with 0 to 2-month-old infants over standard care that was measured by the Parental Stress Scale, or the PSS. So before I go on with my presentation, I'd like to define some terms we've used in our study. So standard care is any form of caregiving that is given by primiparous women or first-time moms to their 0 to 2-month-old infants without knowing or using any form of DBL. It may have influence from her environment, particularly by her parents and or parents-in-law. Next is parenting stress is any kind of stress experienced by the primiparous mother in the care of her firstborn child, which we measured using the Parental Stress Scale. And then lastly, the baseline or the non-parenting stress is the stress experienced by the primiparous mother aside from parenting. This is measured by the use of the Holmes and Rahe Stress Scale. So for our methodology, we use a quasi-experimental study design, and the mothers were Filipino, married, primiparous, 18 years old and above, high school graduate, sole caregiver of the child, and the child was to be 0 to 2 months old, born full term, normal birth weight, no genetic or medical problems. So they were excluded if they have hearing or visual problems, psychiatric illness, and if the child has more than one caregiver, and if he or she was hospitalized after birth. So we used purposive sampling, and we computed to have 26 subjects per group. But with a dropout rate of 20%, we were supposed to have 32 subjects per group, a total of 64. So this consists of the demographic profile questionnaire we used on the mother and the infants. The Holmes and Rahe Stress Scale is a 4 to 3 stressful life event scale, which measured non-parenting stress. And the more events the respondent checks on the list is the higher the score and the larger the weight of each event. Hence, the more likely was the patient to become ill. And in this case, in our study, the more the caregiver abilities of the mother will be affected. So it was used to survey if there are other forms of stress the participants are experiencing aside from parenting stress. So the next is the parenting stress scale. It is an 18-item measure appropriate for both parents, mothers and fathers of children, with or without clinical problems representing pleasure or positive themes of parenthood and negative components. So it was a Likert scale, a 5-point scale, and then the scores were then summed, and then the higher scores indicate greater stress. So this was an alternative to the Parenting Stress Index, the tool used by the DBL. So this is the shortened version. So for our intervention, which was the Dunstan baby language, so the video contained the 5 baby sounds here flashed on the screen, wherein Priscilla Dunstan explained the meaning of these sounds, how they would sound like, and some variations in the pronunciation of these sounds. The video also contained babies of all races who were saying the baby sounds and interventions to be done when a baby has a problem. That is, when the baby says a specific sound. So when the baby says a sound, it means he or she has a problem that must be raised. The entire video was translated to Filipino by a languages professor. So what we did, so we prepared and validated the content of the materials and the tools. So the demographic profile questionnaire, the Holmes and Rahe, the PSS, and the DBL translated into Filipino. So we selected communities with low socioeconomic status in the Philippines. So we invited them, and we said it was a mother's class, and we explained the study to them. So it was a month-long study. So on day 0 or baseline, so we had them answer the demographic profile questionnaire, the Holmes and Rahe scale, the PSS, and then for the experimental group, we let them watch the DBL, and for both groups, we taught them standard care. And then we distributed pamphlets of the DBL and notebooks that serve as their diaries for the experimental group. So after 1 week, we let them answer the PSS, and then a week after, and then 2 weeks after, for a total of a month. So what we used was Data 12. So upon checking the results, so we have the mothers were 18 to 27 years old. The infants were a few days to 2 months old. They were high school graduates, the mothers. So their Holmes and Rahe scale was between 79 to 430. And we compared, this was for both groups, and then we compared both groups to see if they were statistically different or not. And we saw that the p-value was not significant, therefore they were comparable at baseline. So for the PSS scores, parenting stress was measured using the PSS, and the mean scores of both groups were analyzed and were interpreted by p-values. So upon computation and comparison of all the means, it was noted that there was no significant difference in all 4 PSS. There was also no significant difference in the scores within groups during baseline and week 4. It is interesting to note that even though there were no significant differences between the PSS scores of the control and experimental groups through time, a steeper downward slope was observed within the experimental group at times 1 and 2 and 2 and 3 compared with that of the control. This could be due to decreasing parenting stress levels, although conclusions could not be made due to a lot of factors such as the small sample size and short time span of the implementation. These findings correlate with the findings of the researchers of the DBL. When we analyzed the diary inputs, we found out that most of the mothers reported their observation of the sounds produced by their babies, the condition of the baby while the sound was heard, the solutions they applied, and the response of the baby to the solution. The reports, which included that the mothers were able to observe the sounds and do appropriate interventions, implied that the health teachings during the implementation had helped them identify the clues and provided appropriate solution to the problem or need of their babies. Immediate interventions for the needs of the baby had good impact on the child's well-being and also to the mother's confidence in their motherhood. So, as a result, despite lack of significant difference in the mean PSS scores between the primiparous housewives with 0 to 2-month-old infants who practice the use of DBL and standard care and who practice standard care alone, we have concluded that there is a striking trend towards attaining a significant difference in the mean PSS scores. Difficulties in the implementation of the protocol had led the group to recommend the following. So, a better recruitment process should be employed to attain the desired sample size, because we only have 27, 18, and 9 for 18 for experimental and control 9. A bigger scale of participants and longer duration of follow-ups are needed to better appreciate a more significant difference in trends. A more efficient follow-up protocol must be used to avoid respondents from dropping out of the study. This study may be done using other sample populations such as fathers, other caregivers, grandparents. The study can be used as a springboard for future studies that will utilize DBL, PSS, and home trial stress scale as tools. Thank you very much. I'll be showing you the video right now.
To the pre-cry sound, and I've been pulling elements out of the whole cry rather than...
This isn't the actual video we showed them. This is just a clip from Oprah, because the DVD I showed the participants is too long for you, so this is just a clip, just for you to see and hear the baby sound.
Listening to the whole cry.
So Priscilla says that all newborn babies communicate by using 5 universal sounds, and all babies all over the world use the same sounds. The words sound very similar when you first hear them, but Priscilla says that after listening to them a few times, that you, as a mother, can learn to quickly identify each one and understand what your baby is saying to you.
The first word is ne.
Ne.
And this is the word for hunger.
Ne. Word.
The next word is ow, and that's a word for sleeping, and this is based on a yawn reflex. So if you yawn, you go, oh, so, and you'll get an oval-shaped mouth.
Now, you've uncovered a word that you say means discomfort. What is that?
Yes, this is the word he, and you're listening for the H part of this sound.
Because he and ne.
The next sound is air, and this is a lower sound. So if you imagine that your stomach is tightened down here, and you go, breathe in to your stomach, and go,
Oh, I know what that means. Thin, yeah. What?
The next one is and this is when there's an air bubble in the top part of the chest, and the body's using a reflex to get the air out. So it's ne.
It's important that you listen to the pre-cry, which means it's the sound, the coos and the babbles before the cry, so that the sound will be muffled, so you could understand the sound. That's it. Thank you very much.
Questions? I have one. I saw that your study was 0 to 2 months. I'm curious, how long do these sounds persist, and do they change based on the language and the culture of the baby over time?
Actually, race or culture, there's no difference because in the original video, babies of all races were tested. It's actually an 8-year research, so they've done a lot of trials on babies of various races. So there isn't a problem on intercultural differences. But the sounds, they persist until 3 months. So that's why we had it 0 to 2 months. So because the implementation was 1 month, so that we could still hear the sounds for a month. Yeah. And Priscilla Dunstan also said in the video that if you start to listen and respond to the sounds, the baby will be trained to say the sounds and more. So it'll become like learning a language more. Yeah.
Great. Thank you.